So, ladies and gentlemen, I'm going to now talk to you about the ventilatory response to CO2. This is an immense subject. So I had a bit of correspondence with Jennifer back last weekend, and she kindly agreed to my suggestion I should limit my talk to CO2 interactions with neonatal ventilator outcomes and modes, and then a little bit of work that we've been doing, which I hope interests you, on spontaneously breathing babies in relation to sudden infant death syndrome and CO2. So now, over 20 years ago, an inverse relationship was documented between hypercarbia and BPD development. These were observational, non-randomized studies, however. We also know from some studies some time ago that we can really do damage with only the first few breaths at resuscitation in very prematurely born, in lambs, but we assume also from infants. And what these studies showed was that only 6 inflations that were very large could result in a lamb model having poorer lung function. There is also a dose-dependent response. The greater the size of the inflation, the worse the lung function and morphology at the follow-up of these animal models. We also know from another animal model, if you prevent lung and chest wall expansion by either strapping or a plaster cast, but use high pressures, you can prevent the damage. And hence, we've moved from barotrauma to volutrauma. Another way of looking at the same problem is, could permissive hypercapnia be helpful? We know, of course, there's enhanced CO2 elimination because there's a higher alveolar concentration. We know it also improves peripheral unloading and hence oxygenation because of the Bohr effect, reducing the affinity of hemoglobin for oxygen. And we know through less compression, there is improved cardiac output. So it's been postulated that permissive hypercapnia would decrease volutrauma because we'd be losing lower pressures. And in a small randomized study, it was shown not to decrease IPPV duration per se in number of days, but the number of infants that were ventilated at 96 hours. And hence, it was postulated permissive hypercapnia would reduce bronchopulmonary dysplasia. This was a study done in many units across Europe, on 2 census states, if I can put it that way. They collected blood gas data. Nearly 80% of the babies were on conventional ventilation, which meant pressure-limited plus or minus SIMV. Only 10% were on either pressure support or volume-targeted ventilation. And what they found was that when hypercapnia was most common, it was in the first 3 days of life, but only 7.3% of babies were affected as such. And I should say the majority of these babies were premature. But hypercapnia actually was really common. 43% of the blood gases showed hypercapnia, and that was common after the first week. So what these authors postulated, that permissive hypercapnia by 2013 had become part of routine clinical care in Europe. They, however, acknowledged that they didn't know whether the high CO2 levels were actually intentional. So what does permissive hypercapnia actually achieve? Well, this is a study across a number of units in the States where babies were between 500 and 1,500 grams. And they were looking at blood gases in the first 6 hours of life and showed that actually an elevated CO2 had an increased risk of BPD. And they postulated this was due to a vascular spasm causing hypoxia and then causing alveolar maldevelopment. In the Cochrane review, there are 2 RCTs which have shown no reduction in death, BPD, IVH, or periventricular leukomalacia. Although one of those studies was terminated early, it was a 2x2 factorial design, and the other half of the study was about early dexamethasone. And the treated babies, more of them had gastrointestinal perforation. Another RCT of hypercarbia, permissive hypercapnia, was terminated early. And in this case, it was that minimal ventilation was associated with increased mental impairment, an MDI less than 70, and I apologize, this should say 18 to 22 months, or death. Interesting, in all of these studies, they were not able to achieve the level of permissive hypercapnia that they had wanted. As a consequence, another randomized trial has recently been completed. And in this study, they were aiming to differentiate, randomize the babies into normal CO2 levels and a much higher level than had previously been used. When they'd randomized 397 infants, the study was terminated on the grounds of futility. There were no differences seen. This study has only been reported in abstract. I think it's at the moment that's going the rounds of being published, trying to be published. And what was interesting again, they could not achieve the levels of hypercapnia that they wanted. And so what the babies were doing was clearly compensating. By raising the CO2, they were driving the baby's respiratory efforts and minute ventilation to compensate, to get to the level of CO2 the baby felt comfortable at. So I've already showed you this volume-targeted ventilation systematic review and commented on that they have got a reduction in BPD. But let's unpick these studies. So this is a study which set about looking to see if volume-targeted ventilation, i.e. the level of volume delivered, did not vary according to the baby's lung function. And they postulated this would reduce hypercarbia. And indeed it did in the relatively mature infants, but was completely ineffective in the very immature infants. And I would suggest to you that was because not only were they using SIMV, but also a VG level of 4 mils per kilo, and I'll come back to that. This is a somewhat larger study, but nevertheless, they could only test robustly a primary outcome of oxygenation divided by mean airway pressure. And they had to look to a subset to see that where this reached statistical significance, there were no statistically significant differences in any other outcome. And intriguingly, in that trial, they used a volume-targeted level of 4 to 6 mils per kilo. And having talked to the researchers who I know well, I said, well, what did that actually mean on the ground? Did you use 4, 5, or 6? And they said, well, you could choose, which doesn't seem a terribly robust answer. So does it matter what we use? Well, we use, as our physiological assessment of the right level of volume targeting, the work of breathing, PTP. We call it PTPDI, because it's the pressure time product across the diaphragm, the way we actually do it. And these are babies studied during weaning, but we have the same results in acute RDS. And this is studying the babies at 0 volume targeting. And when we put them on 4, and these are all done in randomized order, but I've just put them in this way to make it easy to look at, in both ACV and SIMV, the work of breathing went significantly up. And it was only when we went to 5 it came down, and only when it came to 6 it was lower than at baseline without volume targeting level. You will notice that an SIMV on any of these levels, the work of breathing is always higher than an ACV, and the reason, of course, is that only a few of the baby's breaths are supported on SIMV. As I say, we got the same results in acute respiratory distress in preterm infants. We've also looked in a term-born population, and this is a group of infants that are almost like the lost tribe. If you look at the number of studies on term-born infants optimizing their ventilation, there are very, very few. I commend people to go off and start doing some. But again, when we're looking at these babies, and they're a mixed group of infants who had medical or surgical problems, and that's the benefit that I work on a tertiary unit, which combines those conditions. You can see even in these term-born infants, their work of breathing is significantly lower on 6 mils per kilo. From then, we went on and designed a very small randomized study, one-center study, and the outcome was the time to successful extubation, and these babies were born at or near term. We saw no significant differences between volume targeting and pressure limited, and we measured a number of physiological outcomes, including work of breathing, respiratory muscle strength, and thoraco-abdominal asynchrony, and there were no significant differences. But interestingly, in even these term babies, there were significantly less hypercarbic episodes on the volume-targeted ventilation arm. And as you will know, not only is hypocarbia associated significantly in preterm infants with neurodevelopmental abnormalities, it also is in term-born infants. So I would suggest that its volume-targeted ventilation is also applicable to the term group. Now, we're about to embark on a randomized trial of volume-targeted ventilation in babies with evolving or chronic lung disease. And I think informing what level we choose is from Martin Kessler's data. And this was routinely collected data from their neonatal intensive care unit where they use volume guarantee primarily. And interestingly, and they also have an ethos of permissive hypercapnia from the second week of life, but it's not prescriptive. So they don't say to the various neonatologists on service, this is the level you've got to achieve. But under those conditions, what they found was, as they looked at this routinely collected data, as the babies got older, their CO2 went up, as did the volume-targeted level that they were receiving, which doesn't seem intuitively reasonable. But what they explained, the increased volume-targeted requirements with advancing age, was probably due to upper airway distension in these very immature infants. I should have said they're all less than 800 grams, and increased alveolar dead space. So what we're looking at now is whether in these babies with evolving or chronic lung disease is a higher level of volume target, even than 6 mils per kilo, optimum for their ongoing ventilation. Now, Jennifer said I should say a few words about proportional assist ventilation. For those neonatologists in the audience, you will know there are a tiny number of studies, and some of those are rather old. But we've been looking at this very actively over the last few years. Applied pressure is servo controlled throughout each spontaneous breath. The ventilator is a slave to the patient. And importantly, as far as we were concerned, with babies with high resistance and low compliance, that of course you can apply pressure in proportion to the tidal volume and flow generated to get elastic and resistive unloading. And clearly, this should reduce the work of breathing. This is a figure from Andre Schultz's work, who's done so much to develop PAV in neonates, esophageal pressure, airway pressure, and as you can see, as the baby starts to work harder with an increased esophageal pressure, the ventilator delivers increased pressures, assuming the lungs have got stiffer. Equally, as the baby starts to breathe less hard, the ventilator believes the baby's getting better, so delivers less pressure. But if you think about it, the baby here could be getting tired and at some point actually just stop breathing with an apnea. And if the ventilator then responds by not delivering pressure, there is a problem. This is one of the two studies that Andres has done clinically, and I picked this because this is babies with evolving bronchopulmonary dysplasia. And it's a short crossover study. Nobody's done in neonates a full randomized controlled trial. And what you can see is that oxygenation, as shown by the inspired oxygen, was maintained at the same levels despite significantly lower mean airway pressures and peak pressures on proportional assist. But the rub was that the desaturations on PAV lasted longer than on PTV. And this is the problem of when the ventilator kicks in when the baby becomes apneic. And since this study was undertaken, there's been a lot of work on the Stephanie to actually get a faster backup rate. Now, in all of the studies so far, the amount of resistive unloading has been only to compensate for the endotracheal tube. And we've been really rather cautious at King's introducing PAV into clinical practice because we didn't really feel we knew enough about elastic and resistive unloading levels that we should choose. So we've done a lot of work in lung models with more and more complex lung models. And I have to say, Anthony, my husband sitting in the audience, has driven generations of PhD students completely mad with the amount of data that's been generated. But this is one of the pieces of data generated. And this is complete resistive unloading. And what you can see is oscillations in the airway pressure waveform. Now, we don't know if that's detrimental, but I really don't feel as a neonatologist comfortable with ventilating a baby with that airway waveform. So when we've done our clinical studies, we have not used resistive unloading, but only elastic unloading. This is one of the studies we've undertaken. As you can see, they're all immature infants, and they have either got evolving or existent bronchopulmonary dysplasia. And what this shows is just a brief summary of our results. This is looking at the oxygenation index, which is nearly halved on PAV, i.e. the babies are significantly better. This is again looking at the PT-PDI, and their work of breathing is significantly lower. No difference, however, in CO2. This study had a larger sample size intended, but our statistician terminated it at 12 infants, i.e. early, because in every single baby, PAV was better than ACV. We've just finished another study, which is longer periods of PAV and ACV, and this time she stopped the study at 8 infants because, again, PAV was better than ACV. Wouldn't it be lovely to compare that to NAVA? Now, I want to just say a few words on high-frequency oscillation. I thought for the last 20 years we have completely accepted CO2, what happens with CO2 during high-frequency oscillation. But the recent problems we've been having with the European randomized trial of CDH and the referees suggest that's not a given. But I think what is a given is that during oscillation, we know the delivered frequency is inversely proportional to the frequency. And so if we have a baby with bad CO2 retention, we reduce the frequency during the oscillator. The other thing that I think is also a given is we know different oscillators perform differently, and that the sensor medics performs much more superiorly than the commonly used neonatal ventilators. The thing that, however, seems still, all these years on, controversial, is which IE ratio should be used during high-frequency oscillation. And of course, sensor medics made a selling point that they could deliver 1:2 as well as 1:1, and that would prevent gas trapping. Well, now, nearly 20 years ago, Anthony looked at 9 infants using a jacket plethysmograph, which allows you not only to measure tidal volume, but also lung distension. And what he showed was going from an IE ratio of 1:2 to 1:1, you got a higher tidal volume delivery and no evidence of gas trapping. We then went on to do a study looking at the similar thing and actually showed that CO2 elimination was better on the higher IE ratio. At about the same time, Jane Pillow in Australia looked in a lamb model and showed that ventilation was significantly reduced, impaired on a 1:2 IE ratio. So take-home message, 1:1 is best. I now just want to finally finish off by some brief comments on what we've been doing on spontaneously breathing babies and their response to CO2. Our initial stimulus has been dead space ventilation, where the baby has to breathe through an added dead space. All babies can compensate, it's just how fast they make that compensation. So the time constant is relevant. And what you can see in the prone position, it is significantly longer in the prone compared to the supine position, and that is significantly worse at the high risk age for sudden infant death syndrome. We've also looked at a pure CO2 signal, and this is data looking again prone and supine, and you can see the prone and supine just completely are separate, i.e. again a poorer response to CO2 in the prone position. And then just thinking of other risk factors for sudden infant death syndrome, again this is the ventilatory slope to hypercarbia in smoking and substance abuse mothers compared to controls. And you can see a gradated response, worse in the smokers than the controls, and significantly worse in the substance abuse who also smoke than the smoking mothers. And that was in the neonatal period. This is the same data showing this gradated response. This is at the high risk age for sudden infant death syndrome. Again, both significant, different from the controls. And you can see at the high risk age for sudden infant death syndrome, much less ventilatory response to CO2 at that age in all 3 groups. My final 2 quick slides is just to show how do we use the response to CO2 clinically. Well, this is a baby who was referred to us who had abdominal distension, and they couldn't get the baby extubated in the first day of life. This is the normal response to CO2. As you increase the concentration, clearly the minute ventilation goes up. This is the baby's response when he was asleep and self-ventilating. This is when he was asleep and ventilated. And this is when he was awake and ventilated. He had no response whatsoever. And so I think the neonatologists in the audience have completely guessed this. The baby also, the abdominal distension was due to Hirschsprung's disease. And this baby had what we call in the UK Ondine's curse, or congenital hyperventilation syndrome. And so we made the diagnosis many days before we could get the genetic analysis back. So in conclusions, ladies and gentlemen, measuring the response to a CO2 challenge, I think, does yield clinically useful information on the neonatal unit. I think the experience with permissive hypercapnia has shown us we need to take the influence of CO2 levels in the round. And I think when we want to look at optimizing newer ventilators, we need further investigation as how we take into account the effect on CO2 elimination. Thank you very much for your attention.
Thank you very much, and once again for this wonderful lecture. There's room for one question from the audience. Art?
Thanks very much, Anne. Really a technical question. In the PAV study, you showed the oxygenation index. So let me ask you, oxygenation index in a mode where you've got spontaneous ventilation, how meaningful is it? Because it doesn't give you really the driving pressure, doesn't give you the transpulmonary pressure. How do you interpret it? Can you interpret it? And that's the same for NAVA, by the way, so it's PAV or NAVA.
Yeah. Well, I suppose what you could, the obvious thing to us was that as we put the baby on proportional assist, we could reduce the inspired oxygen. In some of these babies who, had these babies that fight, have hypoxic episodes, etc., we were going from 80% down to 30%. And maintaining the same level of arterial oxygenation. So it was a dramatic effect, and hence why the statistician said, no more after 12 babies.
Okay, thank you. We have to move on.